This is fine. Hi, a very good evening, all of you. Welcome to our second live session of this week. We stopped counting the number of sessions, like I think this is 16th or 17th live. But anyways, this week, this is our second case-based discussion live session. So yesterday's session, we have seen about a case presentation regarding fusion, germination, and also we had several homework questions regarding the same, including on the topic golden proportion or golden ratio. So those who have registered to our courses, you can check out e-classes for reference materials. And if you have any doubts, you need any clarification, feel free to contact us through mail 24/7. So I hope you guys are all ready today. And today we'll deal with another case-based or context-based question. So I hope the streaming is going on fine. And if you have any issues with streaming, it can be either audio or video streaming, do let me know in the comment section. And regarding spreading news about exam postponement or preponement, there is nothing like preponement, advancement. Please don't do it on social media. If there is any official information, if there is any information from the official sources, only then do post the link, right? Because each one of us come across several kinds of information on day-to-day basis. And more or less, the information only creates panic and negativity, and it does no good to anyone. So if you have any information with you, if it is not official, please keep it to yourself, right? Yeah, so with these initial inputs, let's go ahead. And before we start, as you know, the objectives of these case-based discussions is to make the learning process even more fun and enjoyable. And if learning is not fun, then what's the point in doing it, right? So let's go ahead without much delay. Yes, case-based discussions made easy. Of course, learning is fun. So before we start, we have the following courses coming up. We'll be launching them this coming Sunday. Crash course towards NEET MDS 2022. And also, we have updated Mission 12 batch with a new schedule starting from the upcoming Sunday. So all details will be updated to our official website, ptbdacademy.com. And you can even drop a mail at proudtobedentist@gmail.com for any further queries or clarification or assistance in regard to your preparation, right? Now, let's start with a wonderful quote again, a new quote, since it's a new session. You can be successful the minute you decide to be. It's really as simple as that. You can be successful the minute you decide to be. So if you keep poking yourself, if you keep telling yourself that you're no good at performing tasks, you're no good at achieving things, then how do you expect yourself to perform or overcome your expectations on self? So you can be successful the minute you decide to be. Take these words for granted without any second thoughts. So if you want to be successful, it should arise from your thoughts and they will direct your actions and you'll have successful results as a natural consequence, which are born out of your actions as well as your thoughts. So you can be successful the minute you decide to be. So with this amazing quote, let's start with our context-based or case-based question. Thank you, Tanmay, for the feedback on The streaming, Sidra, thank you. Yeah, Madhuri, is it 16th live session, case-based live? Oh, thank you for keeping a tab on it. So, yeah, it is. From tomorrow, we'll add up the number also, right? So, a 3-month-old infant develops a rash on back and buttocks with copious white discharge from ear. Clinical examination reveals facial changes, including frontal bossing, saddle nose, prominent maxilla, and laboratory investigations reveal elevated serum bilirubin levels. Biopsy of liver followed by dark field microscopy reveals the following. So before I show you the revealing aspect, that is the dark field microscopic image, I want you to go through these keywords, the context once again. As I keep on reminding, a context-based question or a case-based question, it is challenging in terms of time management, for sure, because you have so much of information. You should be able to, get to the hints and should be able to answer the question as accurately as possible in a limited time frame. So time-wise, it's definitely challenging, but when you compare it with the normal MCQ, assuming that you have plenty of time, then it's relatively easy to answer because it has so many hints or so many clues which will enable you to answer this question. So 3-month-old infant, clinical features or symptoms of rash on specific areas like back and buttocks with copious white discharge from ear. Clinical examination revealing the face changes like frontal bossing, saddle nose, prominent maxilla. Lab investigations reveal elevated serum bilirubin levels. And biopsy of liver followed by dark field microscopy reveals the following. Observe this wonderful illustration where you can see so many tiny linear structures, almost like corkscrew shaped, traveling in either to or fro direction, that is front and back direction. So dark field microscopic illustration. This is part of your context, even though in entrance exam, you might have an image, but not a video for sure. So at least if you look into this screenshot or any particular part of this video, you should be able to identify what we are talking about. And some of you have already identified the microorganism, also have given the diagnosis. Very good. But before you jump into conclusion, I want you to check out the questions. So this is the information we have. Now with this background information, let's proceed with our first question. What is the most probable diagnosis? Option A, neonatal sepsis. Option B, torch infection. Option C, congenital syphilis. Option D, none of the above. So which one do you think is more appropriate answer? So first of all, what is neonatal sepsis? In brief, it's blood infection occurring in infant younger than 90 days old or 3 months. Early onset sepsis is seen in first week of life, whereas late onset sepsis occurs after 1 week through 3 months of age. Causes include E. coli, Listeria, Streptococcus, herpes simplex virus, etc. Symptoms include body temperature changes, breathing problems, diarrhea, constipation, hypoglycemia, seizures, vomiting, even jaundice, etc. Wide range of symptoms. It has nothing to do with the context which we are discussing. So you can eliminate option A. Torch infection, as you know. Congenital infections also can be sexually transmitted. Toxoplasmosis, T for toxoplasmosis, O for others like syphilis, hepatitis B, R for rubella, C for cytomegalovirus. So torch group of infections. Also HIV and Zika virus have been included in this category. What about congenital syphilis? So as majority of you have been choosing, congenital syphilis would be more appropriate answer because of the dark field microscopic illustration along with classical clinical presentation. Now, before I reveal the answer, let me just get back to the context once again. We can see development of rash on back and buttocks and white discharge from ear. Facial changes including frontal bossing, saddle nose, and prominent maxilla. Liver can be involved. If that's the case, there can be enhanced or increased bilirubin levels, and dark field microscopy gives you the confirmatory diagnosis. So you can see treponema pallidum, spirochetes, corkscrew shaped, and they're motile. Of course, they're motile, and you can see their movement anterior-posteriorly or to and fro, right? So with this background information, as majority of you have rightly chosen, yes, congenital syphilis is more appropriate answer. Now, let me give you some information pertaining to congenital syphilis. So first and foremost, congenital syphilis is caused by transmission of spirochete treponema pallidum, usually from the mother to fetus, resulting in multitude of clinical presentations ranging from asymptomatic premature birth and wide array of clinical signs and symptoms to even stillbirth in extreme cases. So various clinical manifestations include hepatomegaly, jaundice, rhinitis, generalized lymphadenopathy, including rash. Among all these clinical manifestations, especially in early congenital syphilis, rhinitis, consider this very, very important and do underline this point. Rhinitis is one of the first clinical presentations, usually in the first week of life. Copious persistent white discharge is noted, which contains spirochetes that can be visualized under dark field microscopy. Why are we not talking about normal microscope? Why are we talking about dark field microscopy? We'll get back to that a bit later. So rash also usually develops within the first 1 or 2 weeks after rhinitis. So rhinitis is one of the first clinical presentations. To make a note of this point. So rash can be small red or pink colored maculopapular lesions commonly seen on back, buttocks, posterior thigh, and soles of feet. Along with that, there can be several late congenital syphilis manifestations, which include skin and mucous membrane gummas and perioral fissures, facial changes which are seen in the context. So you can observe this particular illustration. You can see various facial changes like frontal bossing, saddle nose, depressed nose, and also prominent maxilla. Along with that, you can also find interstitial keratitis, the right illustration, which is being pointed out through arrow. So facial changes include frontal bossing, saddle nose, prominent maxilla, anterior bowing of shin called saber shins, Hutchinson's teeth, which are hypoplastic notched permanent teeth, most commonly upper centrals. We'll get back to that in detail a bit later. Intellectual disability and cranial nerve palsies, sensory neural hearing loss, and changes in vision. Eye involvement may lead to interstitial keratitis, secondary glaucoma, and corneal scarring. As you can see in the right illustration, interstitial keratitis. So it is considered as non-ulcerative, non-suppurative, more or less vascularized inflammatory reaction of the central corneal stroma, as mentioned in one of the PubMed indexed articles. And this interstitial keratitis, which you're seeing on the right illustration, the whitish layer, it is considered as a form of immune-mediated reaction to the retained microbial products or antigens, rather than an active infection. So it's considered to be an immune-mediated reaction, response to these bacterial antigens. Just keep that in mind. So as majority of you have rightly chosen, option C is a right answer. Do award yourself +4. Now let's move on to the next question. Second question. Which of the following is not a component of Hutchinson's triad? So as Sidra already mentioned about Hutchinson's triad. So what is this Hutchinson's triad? Which of the following is not a component of Hutchinson's triad? Cherish, Hexamer reaction, interstitial keratitis, screwdriver-shaped teeth, hearing loss, all of the above, none of the above. So which one do you think is a more appropriate answer? Yeah. Which of the following is not a component of Hutchinson's triad? You might have heard of all these names: hearing loss, screwdriver-shaped teeth, peg-shaped teeth, interstitial keratitis, Jarisch eczema reaction. So which one do you think is a more appropriate answer? Yeah, first of all, hearing loss can be seen in the context of Hutchinson's triad. So three classical presentations: sensorineural hearing loss or eighth nerve deafness. You might have heard of this n number of times. Eighth nerve deafness, Hutchinson's teeth, that is screwdriver-shaped teeth, notched incisors, centrals, laterals as well, and also interstitial keratitis, which you have seen in the previous illustration. All of them fall under Hutchinson's triad. So which is not a component of Hutchinson's triad, Jarisch eczema reaction. So what is this JHR or Jarisch eczema reaction? So before we see what Jarisch eczema reaction is, I want you to observe these illustrations. On left illustration, you can see notched incisors. Right illustration, Mulberry molars. So you can see globules of enamel being deposited on occlusal surface. So Mulberry molars. So let me review some information from Shafer's as well as other PubMed indexed articles. So Hutchinson's triad, Hutchinson's teeth, interstitial keratitis, and sensorineural hearing loss is relatively specific for congenital syphilis. And also, along with that, information given in Shafer's, like the hyperplasia due to congenital syphilis is most frequently not of pitting variety, but instead it has this characteristic, rather we can say pathognomonic appearance. This hyperplasia involves maxillary and mandibular permanent incisors and first molars, as you can see in this illustration or slide. The anterior teeth affected are sometimes called Hutchinson's teeth, while the molars have been referred to as Mulberry molars. Characteristically, the upper central incisor is screwdriver shaped, and the mesial and distal surfaces of crowns are tapering and converging towards the incisal or occlusal edge of the tooth rather than towards the cervical margin, which is seen in conventional normal teeth. In addition, the incisal edge is usually notched, and mandibular central and lateral incisors may be similarly involved, although maxillary lateral incisor may appear normal. The crowns of first molars in congenital syphilis are irregular, as you can see in the second illustration or the right part of your screen. And the enamel of the occlusal surface and occlusal third of tooth appears to be arranged in an agglomerate mass of globules rather than well-formed cusps. And the crown is narrower on occlusal surface rather than on the cervical margin. So this is some literature review from Shafer's 8th edition. So I hope it's clear. But we haven't still addressed this Jarisch eczema reaction. It's good that you know the reasons. You're saying that it's a kind of hypersensitivity reaction. Of course, yes, immune mediated in response to antibiotic therapy because of massive death of spirochetes. The breakdown products of spirochetes, the antigens, breakdown products, elicit this adverse reaction with the clinical manifestations or signs, as you all rightly mentioned. The Jarisch eczema reaction, it's a self-limiting condition, and it is because of antibiotic therapy. It's not a bad sign. Antibiotic therapy is very much essential, but this is one of the side effects, which usually begins less than 2 hours after giving medication and subsides within 1 day or 24 hours. Let me give you some information on JHR or Jarisch eczema reaction. So Jarisch eczema reaction was first described in literature by Jarisch way back in late 1800s. And in 1900s, a similar phenomena was also reported by eczema. So it's named as Jarisch eczema reaction. Jarisch eczema reaction is a transient clinical phenomena that occurs in patients infected by spirochetes who undergo antibiotic treatment. Antibiotics such as penicillins, cephalosporins, and even erythromycin. In fact, specifically, antibiotics such as penicillins, tetracyclines, erythromycin, including newer antimicrobials such as cephalosporins, levofloxacin, ciprofloxacin, erythromycin, etc., can also cause Jarisch eczema reaction. So it's a transient or temporary clinical phenomena characterized by flushing, hyperventilation, hypotension, tachycardia, headache, vomiting, fever, chills, rigors, as most of you rightly mentioned. And as I said, it is a self-limiting condition because, yeah, as you know, in fact, the exact mechanism is still unclear. It is considered to be multifactorial, but one of the PubMed indexed articles suggests that it is attributed to acute inflammatory reaction, which is mediated by cytokines such as IL-6, IL-8, including tumor necrosis factor alpha. I want you to make a note of this point, right? So the exact mechanism is not known. They say it's unknown or unclear, but it can be attributed to acute inflammatory reaction and through mediation of certain cytokines such as IL-6, IL-8, and tumor necrosis factor alpha, which are responsible for this wide range of clinical features, which some of you have already mentioned. Yes, way back in 1800s, that's the reason why it's named as Jarisch eczema. And let me give you some additional information regarding this. First described in literature by Adolf Jarisch, who was an Austrian dermatologist in the late 1800s, when he noticed an exacerbation of skin lesions in syphilis patients after starting treatment with a mercurial compound. And in early 1900s, a similar phenomenon was reported by Karl Hexemer, a German dermatologist. So basically Europeans, right? So by the way, this Jarisch-Hexemer reaction or JHR is not a component of Hutchinson's triad. And as Rashmi already mentioned, yeah, it's one of the side effects. So I hope the clinical presentation is also fine with you, since many of you are asking for even images, right? We're trying to incorporate as many as possible in a given session. Now, moving on to the next question, third question. So we have two statements here. Statement one, all patients with congenital syphilis exhibit Hutchinson's teeth and Mulberry molars. Statement two, occasionally patients will appear to have Hutchinson's teeth without having a history of congenital syphilis. So what is the validity of these statements? Do you think both statements are true, or do you think both statements are false, or do you think statement one is true and two is false, vice versa? So what's your take on this? Statement one clearly says that all patients with congenital syphilis exhibit Hutchinson's teeth and Mulberry molars because they're components of Hutchinson's triad, right? So do you think it's true? Statement two, occasionally patients will appear to have Hutchinson's teeth without having a history of congenital syphilis. What do you think of it? Do you think you can find Hutchinson's teeth in a patient without history of congenital syphilis? Is that even possible? So let's see how many of you are going to answer it right. Both statements are so very good, well done. Each one of you have chosen either A, B, C, or D, which means one of you is definitely right. So it's amazing teamwork. That's the spirit. Okay, so very good. I think, yeah, some of you are choosing option B, option C, option A. Very good. You're covering all the options possible. Let me review some information from Shafer's 8th edition. Not all patients, let me repeat, not all patients with congenital syphilis will exhibit these dental findings such as Hutchinson's teeth, Mulberry molars, etc. Also, occasional patients will appear to have Hutchinson's teeth without having a history of congenital syphilis. Therefore, one must not be hasty in making the diagnosis of syphilis, particularly in the absence of other conditions of Hutchinson's triad. So this is very, very important. And as a minority of you have rightly chosen, option B is right answer. So those who are wrong, award yourself -1. Smriti, Rishikesh, and some of you. I think only 2 of you have chosen option B. Well done. Sidra, Kishore. Okay, this makes all the difference. Right, so option B is the right answer. So we have standard information from Shafer, so you can go by it. So I hope it's clear. Now let's move on to the next question. Penultimate question, true about Treponema pallidum. They're thin, corkscrew, spiral shaped. They cannot be visualized by direct microscopy, option B. Option C, route of entry is bled in case of syphilis. Option D, route of entry is subcutaneous tissues in case of congenital syphilis. Something seems to be fishy, right? So you need to identify what's fishy. So true about Treponema pallidum. So which one do you think is more appropriate answer? Yeah. Yes. So you have seen the dark field microscopic illustration or video of Treponema spirochetes. So that should provide you some hint in answering this question. So do you think they're thin, corkscrew, spiral shaped? They cannot be visualized with direct microscopy. Is that true? Would you agree with that statement? What about a route of entry? What about route of entry in case of syphilis, in case of congenital syphilis? Even though both the etiology is the same, but the range of clinical manifestations might differ. And of course, the spread, the route. Sai Rajat says A and B are true. Shailaja says all of them are true. Even Sidra says all of them. Rishikesh, Smriti also say all. Danish, Rashmi, Shailaja, okay, right. Even Preeti says all of the above. So, anyways, based on the options which you are choosing, it seems only Sai Rajat is right. Very good, Sai Rajat. And rest of you don't feel demotivated because you're not going to repeat these mistakes again. So let me clarify. As you have seen in this particular illustration, they are corkscrew shaped and they are moving in front or back direction, right? So observe this very carefully. Now let's get back to the question again. So they're thin, corkscrew, spiral shaped. Because of their minimal dimensions or minimal size, they cannot be visualized through direct microscopy. So we need dark field microscopic device, to get proper visualization for sake of diagnosis. So let me review some information regard to this. And before I review, route of entry is subcutaneous in case of syphilis. Route of entry is bled in case of congenital syphilis from mother to fetus, right? So C and D, if they're ulta, then you can consider them as right, all of the above. So option A and B are right answers. So Treponema pallidum is 6 to 15 microns long, as you can see in this video, and 0.1 to 0.2. I'm sure you cannot exactly see the dimensions, but you know that they're very, very tiny and slender, right? So Treponema pallidum, 6 to 15 microns long, 0.1 to 0.2 microns wide. Because of the limited width, it cannot be visualized by direct microscopy and requires dark field microscopy for visualization. Dark field microscopy allows visualization of live treponemes that are thin. Yeah, I'll play the video again. So dark field microscopy allows visualization of live treponemes that are thin, corkscrew, spiral-shaped organisms that may appear to be moving forward and backward. Treponema pallidum may also be visualized by using immunofluorescent staining and special silver stains. These imaging modalities also show the characteristic corkscrew-shaped spiral organisms, right? I hope it's clear. So as one or two of you, yes, option C and D, if they're opposite, then you can consider them as true. But as Sai Rajat, I think Sai Rajat is the only person, and Sujay will get +2. Very good, well done. Rest of you, you can learn from it and not repeat any mistake whatsoever. So this, I'm sure, everyone will get it right. Or is there any twist at the end? Which of the following drug is employed to treat congenital syphilis? So what do you think of it? Which options or which drug do you think is used for treating congenital syphilis? Answer very carefully. Penicillins, cephalosporins, NSAIDs, steroids. So which one do you think is more appropriate answer? So which drug is used to treat congenital syphilis? As you know, the etiological agent, the causative agent is a bacteria, is a microbe. So which drug would you prescribe? Would you prescribe NSAID to relieve the patient from symptoms, or steroid, to minimize any adverse reactions, or cephalosporins, newer generation of antibiotics, or penicillins? Which one do you think is more appropriate answer? Nishita also chose option A, Ignatius option A, Himanshu, Sai Rajat, Shailaja, Divash, Kishore, Sujay has chosen option B. Sujay, I'm sure in your clinical practice you'll be prescribing latest generation cephalosporins, but what about this particular context? Danish, Payal, Agrima, Shriti, Payal 2, Rashmi, Anil. Yes, as majority of you have rightly chosen. Penicillins is the right answer. So infants up to 4 weeks of age and 4 weeks or older, the dose of penicillins varies, and usually it's aqueous crystalline penicillin. Penicillin G, 50,000 units per kg per dose intravenously, or procaine penicillin, 50,000 units per kg per day intramuscularly for 10 to 14 days, right? So you can just make a note of these doses. You can check out the reference materials, which we'll be uploading to e-classes. What about asymptomatic infants with congenital syphilis? So there is a possibility that the infant might be asymptomatic, but he has been diagnosed with congenital syphilis. In that case, the treatment has been mentioned to be controversial. However, CDC recommends a dose of benzathine penicillin 50,000 units per kg per dose intramuscularly in a single dose in these asymptomatic children. Very good, well done. Yeah. Depending upon the age, the dosage and duration varies. Yes, Rashmi? Option A is right answer. Do award yourself +4. So what's the total score you guys achieved in this particular session out of 20 marks? What's the total score? Do post your scores in the comment section. Now, these are the homework questions that you have. What are Moon's molars? First question. Second question, in which diseases is Jarisch eczema reaction evident apart from syphilis? So syphilis, you've seen that Jarisch eczema reaction is a possibility after taking antibiotic course. So in which other diseases do you think you can come across this Jarisch eczema reaction? Do check it out. And third question, what's the reason for tapering and notching of maxillary incisors in congenital syphilis? You've seen Hutchinson's teeth, you've seen the classic clinical illustration. So why do you think you have this tapering incisally, notching of incisors, screwdriver shaped, peg shaped? So why these morphological variations? What could be the reason? So these are your homework questions. Try exploring them, refer standard literature, and feel free to get back through mail for key as well as guidance in regard to your work done. Okay? Yeah. So this concludes our case-based discussion. Yes, so let's look into your scores. Kishore, Shailaja, 16, Preeti, 4. Preeti, you got 4 for this session. But if you have questions along these lines, next time I'm sure you're going to score 100% of the marks. Don't worry. You have nothing to be worried about, because it's important that you commit as many mistakes as possible now itself, so that you're not going to repeat the same later. Sidra, you're not supposed to leak answers to homework questions. If you leak the answers to homework questions, then you're making all of us lazy. I really appreciate your enthusiasm, Sidra. Yeah, please find out and get back through mail with your answers. We'll verify and give you the key. Sai Rajat 11, Kishore 12, Smriti 15, Payal 10, Rashmi 15, Madhuri 15, Priyanka 4, Sidra 15. Okay, very good. Very good. So I hope you enjoyed today's session. And if you have any queries, you need any assistance, you're always welcome. Feel free to get back through mail 24/7. So as exams are approaching, I know how you must be perceiving the situations, how you must be taking up things. But remember, if you want to be successful, you should decide to be first right in here. And I've been getting these questions about parental pressure, societal expectations, which play a very major role, especially in the final days of preparation. All I would suggest to you is try ignoring them as much as possible. As I said, one of the steps to overcome negativity is to stay away from all the negativity, including toxic people, toxic environment. Make sure that you're taking care of that. If that's not possible, then keep telling yourself that this is only temporary phase and you're eventually going to overcome this minor challenge. In life, you'll definitely have even more challenges. I'm not trying to threaten you, but all I'm trying to say is this entrance preparation is preparing you for real life challenges, which means it only makes you stronger, which only makes you more confident in the process. So all you need to do is just believe in yourself and focus on giving your best. So before I conclude, as I keep on reminding, it's all about these three very important factors, which we consider them as preparation mantra: hard work, consistency, and self-belief. I know you have been working hard right from the beginning, working consistently, and now is the time that you should believe in yourself. And even most importantly, on the day of exam, if you don't have that self-belief, I don't want to utter those words, but keep these three factors in mind. Success is all yours. I'm not going to guarantee you success. He or she are not going to guarantee you success. Your neighbors, parents, none of them are going to guarantee you success. Only you have to decide right in here and act accordingly. So take care. Good night. I'll see you again tomorrow at 9:30 p.m. in our next case-based made easy discussions. Love you all. Yeah, the rule is do not utter the words thank you if you want to say thank you. Instead, you're supposed to say either I will give my best, the short form which Payal has mentioned, or we will give our best. Thank you is forbidden in our sessions. Sai Rajat, love the session. Interaction and discussions always boost up a lot of confidence. That's wonderful to hear, Sai Rajat. Most welcome, and I really appreciate your love and affection. Sidra was just kidding. Yeah, I don't want you to leak answers, by the way. Rashmi, actually, your sessions are antidote of all pressure and tension. That's really one of the best compliments, Rashmi. I really hope so. If not, why should one attend these sessions? If these sessions are increasing your pressure, tension, and anxiety, then I would definitely suggest you not to attend them. But if you're enjoying the process, if you feel like you're learning something, if you feel like learning is not just about scoring marks, it's not just about, proving something to others. Rather, it's a part and parcel of self-enhancement, personal enhancement, professional enhancement. So if you have those wider parameters in your mind, you'll enjoy the process even more rather than just restricting to these marks, ranks, and entrance. I really appreciate your feedback, Rashmi. Ritu, please motivate us like this with sessions. Of course, Ritu. And please do participate in all the live sessions, right? Only then you'll receive my motivation. Yeah. Prudvi. Yeah, Prudvi, in which college are you working? St. Joseph Dental College. I'm working as assistant professor, Department of Endodontics. You can find all my relevant details in our website, ptbdacademy.com. Okay. Okay, guys, take care. Ta-da.